So the infectious complications of use disorders. So yeah, if I'm looking at a funny angle, I'm using a different camera, so it's kind of interesting. Quick announcements, of course, these are recorded. Y'all just got that pop-up. Free CME, you will get all that information in the chat at the end and or also in your email.
Just remember that if there's other people in there, just let us know who they are so that they can get their credit, and make sure you rename yourself. And remember, people really want the case presentations. So if you have a case presentation, please let us know. I think what we're going to probably do coming up in these next ones is come up with our own cases as well, just so that we have some.
Yes, so depending on the timing of today, we might just talk through a case or so. But we would really like to, even if you don't want to fill out the form or it's getting intimidating, just, contact us, email us, call us. We can talk through and kind of just put bullet points together. It doesn't have to be a medical student level presentation.
So we got some things coming up on Tuesdays next week. We're going to talk a little bit about the emergency department's role, and then OUD and benzos coming up the week after.
Well, a month from now.
A month.
These are every other week.
That's true.
Okay. This is not correct, but upcoming Wednesdays, tomorrow, contingency management. I know we said that a couple weeks ago. We had an issue, or Sarah had an issue getting on her airplane back to Alaska, and we couldn't make her not get on her plane to Alaska because they're really hard to, reschedule. And so we have that coming up tomorrow, and then Dr. Montoya, who's from NIDA, talking about all sorts of new things for substance use disorders, and he's going to touch on some of the immunizations even that they're developing for things like cocaine. Wednesday, April 6th is not Charlie. Charlie's coming back in May, so we'll kind of stay tuned for that.
Remember, if you want to go through some of the other topics, we just let out one today. I can't recall what it is, though.
The dental caries, the FDA thing with the dental, the tooth complications of the Suboxone product.
Yeah, so that's really kind of interesting. So it's been going on a lot longer than any of us probably thought. But yeah, it's great, great one. But
Give it away.
Okay, 90 different talks on there, so feel free. Again, technical assistance, if you need a little bit of help, please feel free to call us. We're happy to get you the right people if we can't answer it. And so please just put our cell phones in your phone.
So objectives, I'm just going to ignore these just because we will get there and you'll have to answer questions about them at the end, but we will teach you all of this. So background, just really quick on infections. A lot of the population uses illicit drugs. 5%, it doesn't seem like a ton when you're thinking 5%, but it is a ton of people. In the US, and now this is a little bit of old data, as you can see, 2005. We will have some newer data coming up in a minute. It talks about just in the last 12 months, so the number is even higher, and about worldwide. So there's just a lot of people out there who are using, and this is IV. This is injecting. So this isn't just everybody using drugs, this is injecting. So if you are a patient, this is where every patient who's using substances, who, has a brain that's not functioning where it needs to be, who has, that not developed frontal lobe, who's going through withdrawal, is supposed to think about is, do I have a clean surface? Have I washed my hands? How am I mixing my substances? What kind of filter am I using to draw my drugs up into my needle if I'm injecting? Where should I inject this? Do I have a site? Do I have a brand new site? Do I have a good vein? Have I shot all my veins and then I have to use weird veins? And we'll get to all of that. How am I injecting this? The licking the needle. I don't know if we've all heard that. Patients will lick the needle because they say it doesn't burn as much. But just think about all the icky things that live in your mouth. Our mouths are dirtier than dogs, just for reference. And then do I even have a Band-Aid? So these are all the things that if you were to inject anything like in a clinic setting, you would have all of this very hygienic thing. That is not clearly the case. And we'll kind of go through some of this later on, and I'll kind of give you some things that patients say and do that, I don't know, to me, really just make me sad and kind of sick to my stomach, some of it. Reusing syringes. We always ask, I think it's in our gut feeling to always ask, do you share needles? That just seems like a question that everybody is at that point comfortable with, or should be at this point comfortable with asking, because of obvious, like if I'm going to use a needle somebody else just used after they have Hep C and all of that, but even reusing their own needles. Some people are like, oh gosh, I don't share needles. But if you say, do you reuse your own needles because they're cleaner than because it's yourself, it's actually not very safe. I mean, look at this. How often, even using a needle one time, you already have this little lip. Twice, you're like this. 6 times, look at this needle. It's just like, you can envision that microscopic shredding of all those tissues, which is then just introducing the bacterial, especially things that we'll talk about here in a minute. So even sharing of the needles, and this is why if we're going back to the harm reduction topics, which will come up throughout here, needle exchange programs are super important. If someone's going to inject anything, we want them to at least be safe. So these are the big things we're going to talk about. These are the viruses, and I'm only going to touch on these bottom A, B, and HIV a tad, just because by far hepatitis C far and outnumbers. I'll mention them, but we're going to go a little bit down a hepatitis C rabbit hole for a second. But then I also want to talk about the bacteria. I think most people are comfortable going, yeah, Hep C, HIV, duh, IV drug use, but what about all these other things? And I want to just point out, again, language we always talk about. IV drug user is not necessarily, of course, appropriate. So it's people who inject drugs. They are people first. They are not defined by their intravenous use. So the viruses, we'll start with hepatitis C. 81% of the Hep C burden in the US is related to IV drug use. This is, again, slightly old data, but when this is hepatitis C is, of course, a reportable diagnosis. And so in 2018, there were more than over 34,000 people with chronic hepatitis C. This is an important date in Minnesota, and I don't know if Ryan Kelly's on, I'm guessing not, but we all owe a lot to Dr. Ryan Kelly because of the medications. Prior to this date, the only people who could prescribe the medications to treat hepatitis C were infectious disease doctors and basically liver doctors or GI doctors. Now, primary care can prescribe the medications for hepatitis C. The recommendation is still to refer if they also are using intravenous drug use or have any kind of drug use, but this definitely increased the abscess. So what is Hep C? This picture of Mark's on, I apologize, I added this today, but this is one of those things that patients do ask. If you have a spoon, so a lot of people will melt their substances that they're going to inject on a spoon and then draw something up. And if they're reusing a needle, even if the needle looks clean, even one droplet of blood, which this is obviously a bigger droplet, even a microscopic droplet that you don't see, hepatitis C can live on that spoon for 3 weeks. So this can be quite transmittable. If you look at a person who has hepatitis C who injects drugs, it spreads to 2 new people each year. So in about 5 years, that one person has potentially infected 243 additional people with their hepatitis C. Put it in a little perspective. So if everybody were getting treated for their hepatitis C, you can see the improvements in all of these things. And I will kind of go through these a little bit better in a second, but just obviously dramatic improvements in lots of things. Worldwide, a lot of people with hepatitis C worldwide. I'm sorry, I don't remember what all these colors stand for. The black ones are the worst. I do know that. This is from Dr. Sanjeev Arora, the brainchild of Project ECHO. That's what he did Project ECHO for with Hep C, and it's this baby. This is a slide still. So what is hepatitis C? I took off a lot of the information none of us are ever going to remember. Bolded the genotype thing. When you diagnose a person with hepatitis C, the genotype is very important. This can actually dictate which medication, even the newer medications, you should start with. We did an echo a while back now on hepatitis C and the newest treatments where we really dived into all of the Mavorite, all of the new ones that of the drugs. If you all want information on the exact treatments, we have information on those, so please just let us know. It's like an easy cheat sheet in a way. So future burden of hepatitis C, this is an interesting slide. So total deaths related to hepatitis C if the treatments kind of continue as they are now and therefore lack of. And you can just see the decline. Hepatocellular carcinoma, how many people over time, this is decompensated cirrhosis. So the numbers is just sad, scary. A lot of people are dying in primary care because one, it's not being screened for, two, not being treated. Mortality, you can see hepatitis C is this yellow one, is now crossed over way back almost 2 decades ago now, even HIV. So it's a big deal. Potential impact again, this is if we treated 15% of people, you can see already it drops it. Treating 25%, I mean, just treating half of the people, I mean, it's almost in half. This is just why it's so important, especially when there's treatment now. This is just more graphics. I'm not going to go through these in detail. This is all-cause mortality without treatment, with treatment. Hepatocellular carcinoma, same thing. Liver failure, same thing. In case you haven't figured it out, this is important. So what do you do if a person gets diagnosed with hepatitis C? They need to know what it is. They need to know how it can be transmitted. So I kind of put this fun thing over here. It's pretty much transmitted by a lot of things. They need to learn how to avoid transmission to family members. They need to know there's an effective treatment. They can be cured. And more things are coming that are even better, like interferon hardly ever has to be used now, which is one of the ones with the highest side effects. So really avoid sharing any kind of equipment at all that might bump your skin barrier. Other things it's important to vaccinate against the other hepatitises, weight loss if needed, because fatty liver disease also increases the risk of complications from hepatitis C. I'm just gonna move to here. Screening things, if you have a patient you find with hepatitis C and it looks chronic, this should be done right away if you don't know when it was first diagnosed, but every 6 months. Esophageal varices with endoscopy, this is huge. This is a rupture is almost like sudden death unless you happen to be in an OR when it happens. Hepatotoxic drugs, aminoglycosides, we have a whole long list of these, and screening for depression. Depression can really hit people with hepatitis C quite hard. More things, avoid sharing razors or toothbrushes, cover things, don't inject drugs, don't share things, don't donate blood, organs, and tissue. Some of the donating blood things are changing, but stay tuned for that. Still can't right now. Sexual transmission. I had a patient once I diagnosed with hepatitis C, just on her screening. She was in that age group in primary care. She had gotten it from her ex-husband, didn't even know she had it. But that was the only time where she would have questioned it. Her current husband was negative, had never had it, never had any of the stuff, and they had been married for 20 years. And so it's not an automatic. So if you're in a long-term monogamous relationship, they don't even recommend barrier protection at that point. But obviously the more higher risk sexual practices should definitely use protection. Alcohol, as we'd expect, should limit it in people with hepatitis C or not use it at all. Abstinence is recommended. And then this is another topic with the harm reduction I left in here, even though I belabored Hep C a while. A needle exchange program. So these are studies, just 50% reduction in the hepatitis C in places where there are needle exchanges. In places where there's high needle exchange programs, 71% reduction in hepatitis C. And I think if we're going to go government and politics for a second, this is where it's hard. It shouldn't be hard to convince politicians of this because of how much money is this saving us downstream, but it takes money upstream to see that downstream impact. All right, jumping forward, hepatitis A, obviously vaccine preventable. There is still nationwide epidemics going on in little niches, indirectly related to IV drug use. And this is more the hygiene. This is housing insecure communities. We've seen it in certain situations where you have a house where people, they're more nomadic. They move around, they're in different homes. The hygiene doesn't get great. And so they're just more at risk of sharing this. And even if you don't get the second the booster at 6 months, one vaccine is huge. That's all I'm saying about that. And it's self-limited. Hepatitis B, vaccine preventable. There were a lot of people, the highest incidence of new hepatitis B people were people who injected. 2017, new Hep B, a lot of new cases, 20% of people, that's what this 20% means. 20% of people that had the new report in Minnesota with chronic Hep B were people who injected drugs as of the end of 2018. So it is definitely something. The problem is it's not curative. People worry about the hepatitis B because of the cancer and obviously all of that. But hepatitis B can also create long-term complications. My feeling is as hepatitis C gets treated better and more recognized, is that we're going to start noticing a lot more long-term complications, and it's going to be a lot more stress in studies as well moving forward. HIV, mode of exposure, IV drug use is still pretty low, even though it's obviously something we talk about a lot. It's much more the sexual practices, but I don't want to make people think that, oh, we don't have to worry about this, because for instance, most, I would say 90%, if not more, of my women patients who I have taken care of who have injected drugs are all doing a lot of other poor sexual habits. Women don't buy drugs. They use all means. They're in bad, unsafe situations, so they are having a lot of unsafe sex situations in their world. So it is still super duper important. With that, really quickly, I'm not just talking about opioid injection, but methamphetamines, and I don't know if people are really completely aware of this, but when people use methamphetamines, men in particular, they are much more likely to engage in men who have sex with men. They're much more likely to do homosexual acts, which they normally would not do if they were not using, and it's just the nature of methamphetamine. And you will have people deny until you reassure them that this is actually quite common. And so even in people you wouldn't on face value be told, yes, I'm a man having sex with another man, a lot of times they do have some of that contact. They're just not telling you about it. See percentages, just more data. So anyone who is engaging in risky sexual behaviors, especially in areas where there's a higher incidence of HIV, I know Duluth just had kind of a surge up there. Anyone who's injecting drugs, PrEP, they really should be on that pre-exposure prophylaxis. Okay, bacterial infections. This was when we teach the students, I do make this a poll. People always, this question everybody gets wrong because you think that with fentanyl, people don't get as much infection because it's stronger, I don't know. But fentanyl, typically you get this rush and then you withdraw faster. You have more ups and downs when you're using fentanyl, so people tend to need to inject more frequently. So they actually have higher bacterial burden and more infection since fentanyl has kind of taken over. I will warn you in the next, coming up for the rest of this talk, there are some really disgusting pictures at points when we're talking about skin things, so just finish your lunch quickly. Okay, so bacterial infections come in, licking the needles, again, so it doesn't sting, but again, injecting or adding all of those skin floras. Improper cleaning of the skin, they don't always have an alcohol pad or chlorhexidine right handy. We're using the syringes, sharing needles, reusing rinses. So what this means is if a patient is going to inject something and like I said, they filter it, if they're filtering their substances through like a cotton ball, for instance, this is common, or cigarette, the filter of a cigarette, some of that drug does get lost into that filter. And so they will reuse that filter over and over, especially if they can't get more drug, because there is still some drug there, or they'll chew on those, they'll suck on the filter that they use. So the reuse of that filter, that rinse, can increase the chance of infection as well. The more times you inject, obviously the increased risk as well. Currently, people who inject drugs, about a third of them have an active or current skin infection. 70% have a history of having a skin infection. And this could be a mild cellulitis where it's more self-limited. It could be much more extreme. And I don't know, I love this. The things people study is just really cool. But for every 3 years of injecting drugs, you get one abscess. And they define their abscess in this study as something larger than 3 centimeters. So this isn't like a little pimple. This is a bigger abscess. All right. So like I mentioned a second ago, many infections are self-treated. Most of the bacterial infections that people get are normal skin flora. Your staph, usually it's MRSA at this point, or strep. Invasive strep, this is necrotizing fasciitis, everybody. And so that can result. Toxic shock syndrome can result. And then, the non-invasive species, the things that you get strep throat from, ear infections from, you're not obviously going to get those, but that might just cause more your mild cellulitis. So this is a person that got lucky and they just happened to get just the mild cellulitis, with MRSA. Okay. So you'll actually get outbreaks, and outbreaks of weird things. I said most of them are caused by, things that are on our normal skin or things just that are there. But you will occasionally get these outbreaks of Clostridium or Pseudomonas because of people who are using together, or you have a dirty batch. So you will hear about this, it's kind of like an overdose outbreak. St. Cloud just had, 8 people overdose, and that's because the one batch of drugs they had was just, extra potent. So whatever was cut into this drug, because, the drugs aren't so pure, FDA is not approving any of it. So they can get contaminated. This is Clostridium of an arm. And so people who share needles, skin popping, I'll explain in a minute, are even at higher chance. So making sure, that is at least explained to your patients. So this study out of Denver is one of my most favorite places for people to study drugs because Denver thinks everything is okay and they have a lot of infectious issues there now. And this was already back in 2010. Small study. There was only 51 individuals who currently were actively using heroin, cocaine, and meth. This is pre-fentanyl era in the adult. Here's you can kind of see the breakdown. Most were homeless or transient. The percentages of what they were using. Speedball is a combination. Explain that in a second. A lot of black tar heroin. So there's 2 main types of heroin. There's like the white heroin and there's black tar heroin, depending on what side of the country you live on. Black tar is typically a dirtier heroin. It comes out of Mexico. It's more West Coast issue. So Colorado fits in that. Minnesota, we have mostly East Coast because it comes through Chicago, in case anybody wants to know. 49% of people used it in their antecubital fossa, so like where you could get blood draw at the lab, but then used all these other locations, other people as well. And again, we will talk about these other locations in a minute. So the result is that half of them had at least one skin infection in their life. Almost a third had one within the last year. And the ways, so speedball is a combination of basically an upper or downer. So a heroin with cocaine, heroin with meth. So when you do the speedballs, you have, for whatever reason, increased infections. And you can see the people also had a lot of concomitant viral infections as well, on top of all these other ones, which we will, again, get to. But much more likely to have infection if you're mixing substances, which a lot of our patients will do, maybe not even speedball, but they'll do heroin and then meth or vice versa. So, if we have harm reduction services, we do decrease the rate. If you're treating HIV, hepatitis C, we decrease the rates of other infections. So that's kind of that bottom line right there. So people who are more likely to get infected, people who are new to injecting. We will have people who are deathly afraid of needles. And I know people probably question, how can you be deathly afraid of needles and use substances? Often those patients, their first few injections were done by somebody else. And so if that somebody else isn't there or somebody isn't there to help them inject and they do it themselves and they miss the vein, much more likely to get infected. I mean, we've probably all had someone try to put an IV in or draw blood, and, they have to dig around, and, we've had alcohol swab first. Skin popping. So when people really have no access to their veins anymore, they just can't get to them, or for some people like this, they do the skin popping. So they literally just put the needle in and inject wherever they hit, whether it's subcutaneous, it's into the muscle, much higher chance of infection there. Again, speedballs, how frequently you inject, and then being HIV positive, regardless of viral load, increases your chance of bacterial infection as well. Same thing we talked about. Booting, I want to explain this because it is something new. So a person who injects, kind of like that filter we talked about where there's a little substance left over, when you inject, there's a little bit of liquid in that needle, even if you're using an insulin needle that's tiny, but there's a little substance in either in the syringe or in the needle. So they will inject and pull back and inject and pull back. So they're like flushing the needle and syringe with their own blood to make sure they got all the drugs. That increases the chance of infection. Sharing things, the drug adulterant. So this is the things that would lead to like the Clostridia or the Pseudomonas is what was in there when it was cut. Sheetrock, one of my favorite things. Like heroin, especially the white heroin we have in Minnesota, gets cut with sheetrock because it's white, or talcum powder, or baby powder, or whatever looks white and powdery. So, the drug dealers can sell it saying there's more drugs there when really it's all this other stuff. And then how are they, preparing? You have to add some type of a liquid to solubilize the solid drug. Are they spitting it and that's their liquid? Are they using sterile saline? Probably not. Are they using sterile water? Probably not. We've heard drainage ditches, toilet water, lots of different things that just shows how horrible of a disease this is, that, that is what, people are doing. Increased risk prisoners, military recruits, that's because of the confined spaces. So similar to the living environment, if a lot of people are living in transient housing altogether, it just increases your risk. And the same with COVID. More people you throw in a small place. Men who have sex with men, as we talked about, and then crystal meth. That's the one you dissolve and inject. So the most common are just going to be your skin infections, your cellulitis, your local infections caused by right where you are injecting. Boils, carbuncles, impetigo, just when you're more MRSA, styes, and things that are just more superficial. So to go a little bit deeper, did it? Okay, abscesses. So it has more inflamed tissue. It's more deep into the skin than just in that top layer of cellulitis. Usually there's cellulitis there too. Needs drainage. When I was in medical school, abscesses, you didn't have to give an antibiotic to. You just drain it because it's a contained thing. When you have somebody who injects drugs and they have an abscess, you should give them antibiotics because that skin has more cellulitis than the average, and they're going to keep injecting. So they're just increasing the risk of having that smaller abscess get worse. People who are using substances will sometimes start picking more too. So they're going to try to drain their own abscesses, which I have seen 1,000 times, and they'll come in and you'll be, it's extreme. And aside, I want to say about this. So another thing I learned is if someone has bilateral cellulitis, it's probably not actually cellulitis. Cellulitis is going to be a localized thing, or even abscess is like a localized thing. And if you have it on both sides of your body, it's probably something else. It's an autoimmune thing, or it's a heart failure thing, especially lower extremities. I actually had to admit a patient because she had bilateral upper extremity cellulitis and abscess. And the hospitalist didn't want to, no one wanted to believe me that this is bilateral cellulitis, but she injected on both sides of her body with the same needle. And so she legitimately had bilateral cellulitis. So everything we've been taught that it can't happen, it really can in the right situation. I was looking at you, Nancy. Not saying you taught me that, but okay. And then MRSA, you're pretty much going to universally assume MRSA. You know, people, obviously healthcare workers, higher risk, people who are incarcerated, higher risk, the living situations, again, higher risk, immune system changes, higher risk. Just jump right to this. I mean, jumping to treating with Keflex in a person who injects substances is probably wasting your time, especially if you're doing it as an outpatient, because you're not 100% confident that if this doesn't get better, they're going to come back. So you want to make sure you give them what's going to help them. If they've had MRSA before, spider bites, they'll come in and say, I have a spider bite. In jail, it's funny because they'll say I have a spider bite a week into their incarceration. You're like, no, you just have an abscess or whatever. So keep that in the back of your mind always. So group A strep, so this is some of those more icky things. This is actually toxic shock, not necrotizing fasciitis, if you want to differentiate. A lot of people are carriers of group A strep. Dogs, for whatever reason, are carriers of group A strep in some situation. So they can cause, mild things like strep throat or ear infections, or they can cause very, very significant, severe infections. Sorry, I told you I was getting gross. And necrotizing fasciitis, again, the flesh-eating disease. I've seen it in the Marshall Islands. It's scary because it goes very, very, very fast. And so it's not just the skin and deeper tissues, it goes all the way through the fat as well. Very, very painful. The problem with this is sometimes it's, initially, it's very hard to diagnose it, actually. The person will come in, it looks like cellulitis, it looks like a small abscess, but they're like writhing in pain. And so it's hard because there's so much stigma and so much judgment and so much in and out of clinics that you're just like, get out of here, here's your antibiotics. When you palpated it, you drained it, and you tried to follow the tracks, it's much deeper than you think, and it moves, again, very quickly. Urgent medical attention. Depending on where this is located, it can create very bad, fast death. Very similar with toxic shock. This one's even more hard because flu-like symptoms, muscle aches, diarrhea, vomiting, confusion, like everything else right now. And again, very life-threatening. So you're, checking lab work. Anytime I have a patient who has an infection, who injects substances, I always get labs just in case. Even if it seems like something simple, like a easy cellulitis, again, you never know if they're going to make it back. So I'm always a little bit more aggressive in at least my workup, just to make sure I'm not going to miss something, because it can go bad very quickly. So fever, low blood pressure, they're going to look more septic. Uncomplicated, outpatient antibiotics. More complicated, we had this whole debate a couple of weeks ago on a Wednesday ago about what do you do if they need long-term IV antibiotics? Do you leave them in the hospital? Do you send them home with oral? Do you send them out with a PICC line? You really have to know your audience, and you have to know your patient, and you have to know, do they have transportation back? If they have a PICC line and they need to come back for their antibiotics, can they even get back for their IV antibiotic infusion? Can you send this person who's been injecting fentanyl into a swing bed or a nursing place where they can get their antibiotics? Good luck. If they're going to be in withdrawal, they're not going to like you. So now you have to factor in your MAT, MOUD into this, because this is a direct port now. They love you if you put a PICC line in them and don't help them, because now they can inject much easier and much less painfully into their PICC line. And so this is hard. And I talked to Dr. Amanda Nasca, one of our infectious disease friends, and she's like, it's very patient specific. She said there is not a one size fits all. And then obviously these things are going to definitely need surgical consult. You want to make sure the anaerobic and gram-negative are also covered, because those are going to make it move quicker. But the antibiotics can be pretty long term. If they have staph in their blood, they need an echo. We'll get to that in a minute. And IV therapy. Okay, osteo, so all musculoskeletal infections, septic arthritis, osteomyelitis, infection of the bone itself. I love this. Common location, sternoclavicular joint. Why that's a common location, I don't know. SI joints, the spine, the knee, I had a patient, it was right in her femoral head, patient in residency who used a lot of cocaine, and he kept getting his replacement joint infected. So if anybody has any kind of a joint replacement, that's where it's going to go. So just being aware, you had the patient. I
had a patient with it in the C-cervical spine, and he got an abscess right in the C-spine, and then he signed out AMA, so it was just a complete disaster. Yeah.
So, and most of the time it's from hematogenous seeding. So it gets in their bloodstream, it goes somewhere else. It can extend from their cellulitis abscess, much less likely unless it's like a toe. So usually it is spread. Pain, they don't even always have a fever, just pain over that site. So it's just going to be important. Again, this is the high risk population for having weird infections. You've got to look into it. Okay, so high risk injection sites. Again, people lose good access in their arms or, in their legs. I had a patient who was in our hospital and lab couldn't even draw her blood because she didn't have any good access. And finally, I stood in the room and let her draw her own blood for the lab because they were just poking her a million times. And she took a random poke into the top of her leg, right into her thigh, and drew out 3 tubes of blood because she knew her only vein was a non-visible one in the middle of her thigh. Whatever. But I mean, just think about certain areas. You're much more likely to be an infected area. Femoral vein, they call it a groin hit. I mean, does not as clean as your intubral fossa. Jugular vein, they actually have a name for it. Pocket shot. I had a patient injecting into her jugular vein, and the needle broke off. So she had she had like 2 needles in her neck on X-ray at this moment. So obviously very scary for a lot of different reasons. And then the same kind of agents. This is only in here in case you really want to read all the small print. It just explains what you should be using to treat and where. Okay, endocarditis. This is why they need the echo. So 1 to 3.5-ish per 1,000 drug users, so people who are injecting drugs per year. So this is common, actually, considering in Little Falls we had 100 patients, and Little Falls is a small community. That's a lot of people with endocarditis. If they have other infections, the same kind of thing, seeding, the abscess, even just cellulitis increases the risk. They have a history of it, of course. They grow it out in their blood. I mean, it's going to go there. Higher with people who inject cocaine and higher with people who are HIV positive. You can see the difference is actually quite significant. This is pretty extreme endocarditis, which is why this person is no longer living. So it can be infective, it can be septic, mycotic, so fungal, septic, or from sepsis. Everybody who has bacteria in their blood needs an echo to look for this. Left-sided is actually very similar rates to people who don't inject drugs. So just because you see it in a person who injects drugs, you got to be a little careful. But if it's in the tricuspid valve, 70% of the cases are going to be more likely related to injecting of drugs. So not all, though, just most. Here's what it looks like on the echo, the nice little growths on the valve. So fever, shortness of breath, chest pain, murmur. Always got to listen to the patient's heart, always. Even if they're not an injection person, if you're doing an intake on a patient, regardless, you have to listen to the heart. It sounds stupid to say that, but it happens all the time. Mortality rate if treated is not that bad, but if it's left-sided, you can get much more complicated. That infection can break off and go to places you obviously don't want it to go. IV antibiotics, similar to people who are not using substances, so they don't have anything more, but you again have to deal with these outpatient issues. I just can't stress enough, though, if this patient's inpatient and they have endocarditis or they have something that needed to be admitted because of their infection, you have to know they're going to go into withdrawal. That has to be addressed. It can't be forgotten because that person will leave AMA if they're in withdrawal enough because it is that bad. And that could be even worse. So making sure your hospital is ready to take on treating that patient with like real meds, like the buprenorphine products, not with clonidine and hydroxyzine, because they won't work. Short course, if it's right-sided with, you know, sensitive meth or staph, fine. Sometimes surgery, I mean, I have not met a heart doctor who will do surgery on a person who is actively injecting drugs. They will if they absolutely have to, because of the severe nature of their valve dysfunction. I have a patient who had to get a valve replaced due to infective endocarditis. The surgeon wouldn't touch her for 6 months. She was on more cardiac meds. I mean, she looked like an 80-year-old person with horrible congestive heart failure that was like an autoimmune version. She was on so many heart meds as a 22-year-old, but stuck to it. Still in recovery now years later, and did get her new valve. But you, of course, just like the hip, when you have a fake joint, that's high chance of getting infected. A prosthetic valve, even higher chance of getting infected. Pulmonary, things we don't always think about, and it's not always going to be an IV related, but they're going to have more atypical clinical and X-ray findings. So anybody who's using substances, you got to be aware of it. More chance of having community-acquired pneumonia than anybody else. A lot of them also are smoking. If they're, you know, using substances, whether injecting or smoking or snorting, they're also smoking. I had a patient with very severe aspiration pneumonia, and that is also an issue, especially if they're using opioids or benzos and they're, you know, respiratory depression, they're increasing their chance of having an aspiration. Immunocompromised, HIV, of course, nutrition. You know, if they're a person who's using a lot of substances and they're not taking care of their other, you know, needs of adequate nutrition and hydration and bathing and stuff, you know, they're at an increased chance. And then, of course, if they're hospitalized, same things as anybody else who's hospitalized, but the aspiration pneumonia is disproportionately elevated. And then you got to worry about the TB, the HIV, other aspiration things. These patients, again, if they're living in congregate living, much higher. If they have endovascular infections, they have endocarditis or, you know, valve disease, they can actually get septic pulmonary emboli, which can then create very significant lung disease. And diagnose HIV with weird lung infections in patients who are using substances. I put these all in quotes on purpose because this is not what I would ever call a crack house, but that is what slang it's called, and that's what patients will call it. So if they're living in houses where there's a lot of things going on, they go to like big parties where everybody's injecting, they're living in homeless shelters, they're incarcerated or they were incarcerated, much, much higher chance of having tuberculosis. We had an outbreak in a jail, and that was super fun to deal with. They often have delayed diagnosis, one, because they have delayed presentation. They don't necessarily understand they have symptoms. They have a cough, and they're like, oh, it's because of my cigarettes. Or, you know, they go into healthcare and no one gives them the time of day, and then it can get worse. Shotgunning, another term, is if I'm smoking my crack and then when I exhale, there is still a little drug in there, but then I blow it into the next person's face, so then they can also get a little of my crack without having to smoke it. They can get a little high from that, but then of course you're spreading COVID really close there. That just is what that is we think of now. So broad spectrum, as you'd expect, prolonged course, empirical treatment, you have to treat them for not only TB or one infection, you have to kind of cover all of it until you know. Same kind of thing here if you want to read all the small print. Okay, so the rare things, these are just kind of things that have happened and happened. So tetanus. So, I mean, listen, 15% of the cases in this 2-year span, I mean, tetanus is obviously not as common anymore, but 15% of them in the country are related to IV drug use. You know, do they have an updated tetanus shot? You know, they got a tetanus shot before they went to 5th grade. Did they get another one after graduating from high school when they should have? Did they graduate? Did they ever get another one? So, I mean, think about the patient population. Not that it's exclusive to that 20s, but if they never got that next tetanus shot, I mean, they're at high risk, sharing needles, they're living in tight spaces. If there's one, you got to kind of screen everybody. It's going to be, again, in that cluster. Necrotizing fasciitis, there was this huge outbreak of it in England and Scotland and Ireland because of a bad batch. Pretty sad. And then Clostridial. So this is more of the black tar heroin. We're not going to see a ton of this in our area, but it can happen. And it happened in California in the 90s. This huge thing with botulism got into what it was cut with. And very bad. It goes very fast. You know, they need antitoxin, debridement, a lot of things. And then anthrax. It's just unbelievable to me. But again, the spores got into the batch that happened. We had this span of Scotland. 17 people died out of 15 because these spores got in, and this goes even faster. Mortality, 20% with antibiotics, obviously much less, but I mean, you can go to death from, you know, injection in less than a week. But you can also get it inhaled. You don't have to inject. You can just inhale it. And this is even worse than the injecting anthrax. It goes much faster. You know, inhaling things hits the blood-brain barrier faster and goes through all of that faster, gets through the bloodstream faster, almost always do. So preventing, it's patients, you know, it is having these harm reduction conversations. It is uncomfortable to tell your patients, go pick up these syringes. You know, you want them to be done using, but if a person's not ready, or you're fearful that they're going to take their treatment, but then they might not, it's still important to have these conversations. You want to educate them on that hepatitis C risk and the skin infection risk. You want to make sure they know how to clean, you know, their injection site. You want to talk to them if you need to use a different injection site. Where should you use? Should you use a hand or a foot? Well, a foot's in a sock, it's dirty. So you want to talk about these things, even though it does feel uncomfortable. So avoid all of that. I had a patient sip the water from, not like the bong water. So they, you know, they put their meth in like a bong thing that they light, and then they breathe in the fumes of the meth. But there's the liquid in there, the water is in there, and then would drink it because there was still some drugs in there. Yeah, there's just a lot of things. Talk to them about the different places. I just kind of mentioned this, hands, feet, legs. Gets worse. Like if you have this infection, you can imagine that there's less room for swelling and you can have more disability down the road. And avoid the very obvious things, but this happens. I've seen it. I've seen abscesses on the breast from injecting into those veins. Not personally seen a penis infection from injecting, but I've seen all the other ones. So needle exchanges, supervised injection facilities. This is obviously going to be a huge topic in our state. The biggest thing is this is harm reduction, 100%. Making sure your patients are using birth control, they're using protection, vaccinate where you can. And yeah, that's a long talk. I apologize. It's almost 1:15 already. So, again, if anybody has any questions or feedback and thoughts, you can always reach out to us.
Any questions? Anybody got any questions about some of the infections and things that can come from IVUs? All right, so next week I think we will do our best.
2 weeks.
What's that?
2 weeks.
2 weeks. In 2 weeks, we're going to do our best to have a case kind of hooked to this as well. So make sure that you come back. We're going to talk a little bit about ER, the ER's role and what we all do. So, all right.
I have several cases. Yeah. So if nobody else has one, I know we have a lot of people who are in communities where ERs haven't done much yet, or there's some fear, but we have a lot of good stories too. So,
all right. Well, thanks everybody for coming. We'll see you again in 2 weeks.